Good evening, everyone. Today we'll review major immune and infectious disease concepts that frequently appear on your NCLEX Next Gen exam and also align with oncology nursing practice. Today our goal is to build you kind of a strong conceptual foundation so when you're getting questions that ask you to apply rather than just to recall the information. So I'll give you pathophysiology assessment and nursing interventions and then NCLEX style considerations for this week. Okay, first we have type 1 hypersensitivity reaction. This is anaphylaxis. This is IgE mediated immediate hypersensitivity. So on first exposure to someone who has an allergen, the body will become almost sensitized and it produces IgE antibodies that will bound to their mast cells, also known as the basophils. Okay, when the patient is re-exposed, they have a cross-linking of IgE triggers of histamine, tryptase, leukotrienes, which causes vasodilation, increased capillary permeability, and bronchospasms and edema. Clinically, your patient's going to have a rapid onset minutes after exposure. The reaction can progress to life-threatening anaphylactic shock with hypotension and airway compromise. So for your need to knows, early recognition is always going to be key. Hives, swelling, angioedema, wheezing, hypotension, like I said earlier. Some patients may even have immediate GI symptoms. So your first line intervention is going to be epinephrine, IM immediately. You're going to maintain their airway, IV fluids, antihistamines, corticosteroids like Solu-Medrol or dexamethasone, and be ready for airway compromise. So, on this next gen exam that you guys are kind of preparing for in your exams and you're preparing for, they're always going to say what's your first action. So you're always going to choose epinephrine IM over an antihistamine, and you're also going to watch for a delayed biphasic reaction. Okay. This also, we can link this to skin test allergies. So skin test for allergies, they typically rely on IgE mediated type 1 mechanisms. Okay, type 2, cytotoxic cytolytic hypersensitivity. So the mechanism for this is you have IgM or it can be IgG antibodies that are directed against antigens on the cell surfaces or extracellular matrix. Examples of this would be a hemolytic transfusion reaction, Rh incompatibility, autoimmune hemolytic anemia, or Goodpasture syndrome. Nursing implications, you're going to monitor for transfusion reactions such as chills, back pain, hemoglobinuria. You're going to stop the transfusion immediately. Give the patient IV fluids, monitor their kidney function that they're still perfusing. If a patient develops a sudden hemoglobin drop after transfusion, you want to think of a type 2 hypersensitivity. Also, please make sure that you know examples of type 1, type 2, 3, and 4, because that could easily be a select all that applies. So make sure you know at least 2 to 3 under each type. Okay, next we have type 3, which is the immune complex mediated hypersensitivity. The mechanism here is the antigen antibody complexes form in circulation, and so they deposit in the patient's tissues. So glomeruli located in the kidneys, the joint spaces, vascular walls, and then the complement activation for C3A, C5A, and then your neutrophils are recruited, and then the tissue is damaged. So some examples here is systemic lupus, erythematous, post-streptococcal glomerulonephritis, which is for really common in children who are post-strep, and then serum sickness. Again, making sure you know examples of these. Complaints from patients may include fever, arthralgias, rashes, renal signs, hematuria, proteinuria. Treatment is going to be remove antigen exposure, give immunosuppressants in supportive care. NCLEX tip, you're going to look for antigen antibody complex deposition in the stem. Okay, type 4 is called a delayed cell-mediated hypersensitivity. Mechanism here is T-cell mediated, not an antibody. On re-exposure, the sensitized T cells, CD4, Th1, CD8, cytotoxic, they're going to release cytotoxins or directly kill cells. So this is going to give a delayed response. So in 24 to 72 hours or even more. Examples of this would be like contact dermatitis, so poison ivy. It gradually kind of gets worse. You know, you get the oil on your skin, you scratch it, and then you touch a different area of your body, and then that becomes itchy. The tuberculin skin test, also known as the PPD, and granulomatomas reactions. Skin test allergy portion. So the PPD, the Manitowoc test for TB, is an example of a type 4 delayed hypersensitivity reaction. Nursing implications, you'll want to remember to assess for induration, not erythema alone. So the timing does matter, so 48 to 72 hour window. For patients who are immunocompromised, the patients can get a false negative for a PPD. So if the question mentions 48 to 72 hour delayed skin response, you're going to think of a type 4. A memory aid to help you remember all of the sensitivities is acid. So A is anaphylactic type 1, C is cytotoxic type 2, I is immune complex type 3, and D is delayed type 4. Okay, so for anaphylactic shock, I'll go in depth. I'm going to give you a lot of pathos, so just make sure you have a good understanding of it. So this is a massive IgE granulation. So histamines, leukotrienes are recruited, widespread vasodilation occurs, increased capillary permeability, so you have a major fluid shift out of vascular space, which is going to cause hypotension, tachycardia, and airway edema. So nursing priorities here, again, ABCs, airway, breathing, circulation. You're going to give epinephrine IM right away, secure their airway. They may need to be intubated as well. IV fluid bolus to counteract the hypotension. You're going to monitor them for arrhythmias due to that major fluid shift. Also, too, just think it's not just fluid. Think of like also the electrolytes that are shifting with that as well. You want to make sure you have resuscitation equipment nearby. After acute care, you're going to monitor for biphasic reaction, which usually reoccurs 8 to 12 hours later. You're going to provide patient education. Again, on allergies, they need to wear a medical ID band. They need to avoid their triggers and always carry an EpiPen with them. So for NCLEX style next gen questions, concepts you should be thinking of is, which medication should be administered first? What is the priority nursing intervention? So for that, it would be epinephrine, and then obviously maintaining airway and administering epinephrine for the priority nursing interventions. Okay, so for tuberculosis, pathophysiology is caused by tuberculosis, Mycobacterium tuberculosis, transmission via airborne droplet nuclei. Once it's inhaled, macrophages ingest bacilli, but they can persist, right? So then they form granulomas, which is considered a type 4 hypersensitivity, like I stated a few slides back. Because tuberculosis requires cell-mediated immunity, immunocompromised patients are at a risk. So skin test, allergy link, the PPD or interferon gamma release assays detect cell-mediated immune response, which would be a delayed hypersensitivity. So false negatives are possible with patients who are immunosuppressed. For nursing need to knows, any cough over 3 weeks, significant weight loss without trying, night sweats, coughing up blood. For diagnostics, they're going to do a sputum, AFB smear culture, a chest x-ray, a TB skin test. A treatment is multi-drug therapy, so INH, rifampin, pyrazinamide, ethambutol for a prolonged period. So what I will say is test period for nursing period, NCLEX. They love to test on these medications, so you need to know about INH, rifampin, ethambutol. You need to know how long the total course of that medication is. You need to know education and precautions for patients when they go home. You also need to know when they are kind of out of that TB window, like how many cultures or AFB smears do they have to do. So it's really, really specific timeline with these meds. Also, you need to know side effects of these meds. Some affect your hearing, some affect your sight. So make sure you look those up and you know those as well. Healthcare workers, they are put at a significant risk, so facilities do have to implement TB infection control measures, so administrative, environmental as far as ventilation, respiratory protection with N95 respirators, and airborne precautions. For me, the one way
that I remembered precautions, I tried to group them and put them in mnemonics. So if that helps you, you will have to know precautions on your exam. So if you have a nurse that's caring for a newly admitted patient with suspected pulmonary TB, should wear an N95 respirator and place the patient in an airborne infection isolation room. Because patients with HIV are at higher risk of progression from latent to active TB, the overlap of TB and HIV is critical, when you're looking at oncology and immunocompromised populations. Okay, HIV infects CD4 T lymphocytes and macrophages. So over time, the viral replicates itself, which leads to a decline in CD4 cell count. So that's the big point here, is that patients who aren't complying with art therapy, choose not to do art therapy, not only are they putting their self at risk for developing AIDS and all of the opportunistic infections, but they also will have a decline in CD4 cell count, and that's not something that, once you lose those cells, they don't come back, okay, no matter what you do. So total immune dysfunction, opportunistic infections, make sure you know that. So key tests you should know here is EIA, enzyme immunoassay, or antigen antibody combination test, which is going to detect HIV antibodies or P24 antigen. You also have the NAT, which is the nucleic acid test, detects viral RNA. The earliest detection after exposure, 20 to 33 days, when antigen antibody tests may still be negative. Your CD4 cells, it's a key marker of immune status in these patients. So CD4 count guides providers' risk of providers letting patients know their risk of opportunistic infections and treatment decisions. So when should they start antiretroviral therapy and prophylactic therapy? So antiviral medication, also known as ART, A-R-T, is initiated early to suppress the viral load. So that's the goal, is to suppress their viral load, preserve their CD4 cells, and reduce transmission. Okay, let me say that again. The goal of antiviral medication, also known as ART, is to initiate early to suppress the viral load. That's one. Number two is preserve CD4 cells. And number three is reduce transmission. Okay, so if it's undetectable, it's untransmittable. Here I have listed some opportunistic infections. There's a lot of them. These are usually the most common ones that you should know. So PJP, Kaposi sarcoma, which is a form of cancer, cytomegalovirus, CMV, retinitis, Mycobacterium avium complex, also known as MAC, and then cryptococcal meningitis. So make sure you know those signs and symptoms and treatments as well. For antiviral medications, you should know that, initiating early to suppress viral load is important. We want to preserve CD4 cells and reduce transmission, so those are the goals. So again, initiate early to suppress viral load, preserve CD4 cells, and reduce transmission. So if it's undetectable, it's untransmittable. So although extremely rare, exposure via needle stick, mucous membrane contacts are possible. So healthcare workers, obviously, we're at a really high risk because of what we do, our field that we're in. So post-exposure prophylactic PEP is critical. So standard precautions must always be used. Okay, confidentiality reminder. So HIV status is highly sensitive, as you guys know, so only those directly involved in care or required by law should have access. This is extremely important. Counseling should emphasize prevention, partner notification, and adherence. For transmission-based precautions, so standard precautions, you're going to treat all body fluids as potentially infectious. Transmission-based precautions, this is used in addition to standard precautions. So depending on route of transmission, you have contact, droplet, and airborne. Contact precautions for pathogens spread by direct contact, so MRSA, C. diff, gowns and gloves are required. Droplet precautions, large droplets here, okay? So influenza, pertussis, a lot of respiratory illnesses, so you're going to mask within 3 feet of patient. The patient also should wear a mask while being transported, through the hospital or in the clinic. Airborne precautions for pathogens transmitted via small droplet nuclei, so TB, measles, varicella. The way I remember that was MTV. So M is measles, T is TB, and V is varicella. And then obviously this is before COVID because I graduated school way before COVID. So add COVID-19 to that as well. Okay. So you need an N95 respirator or higher. Some people will have like PAPRs as well that have filters on them. So airborne infection, isolation room with negative pressure ventilation. Here I've included some next gen style prompts, so these could easily be select all apply, what's the best or first action, just to kind of integrate your learning. If you guys have any questions for this week, please let me know. Please make sure that you are commenting on the video other than just saying thank you. I will see you guys this week. Professor Bronstein and Professor Koning will be covering for the Monday group. Friday group, I will see you in the evening, and then Rebecca will be covering during the day. If anybody has any questions, please let me know. I hope you guys have a great weekend.